Okay. Well, good morning and good afternoon to some of you. I am Dr. Maisha Standifer, Healthcare Policy Research Director at Satcher Health Leadership Institute at Morehouse School of Medicine. And I am just elated to be the moderator for today's session. It's entitled Diversity Matters in Research, part 2 of a 2-part series sponsored by USF Health, We Care, and Reach Up. Next slide. This series will enlighten researchers and community members on the historical context of medical and research mistreatment among communities of color contributing to distrust. And of course, I am excited, as I mentioned, USF Health and We Care to introduce to some and to just highlight again some of the best assets that we have at USF and the introduction of Dr. Angela Hill. Dr. Angela Hill is a tenured professor and associate dean of clinical practice and past chair of the USF Tanasia College of Pharmacy. Dr. Hill received her Doctor of Pharmacy degree from Florida A&M University, received postgraduate training in the neurosciences from the Neuroscience Research Institute, and holds a certificate in medication management. She is also a fellow of the American Association of Colleges of Pharmacy and a consultant pharmacist in the state of Florida. One of her many duties is as the Associate Dean of Clinical Affairs includes her serving as the preeminent project manager for We Care. And We Care is a community-based participatory research entity within the College of Pharmacy, where she coordinates activities within the community to recruit, retain, and educate minority and vulnerable populations on research participation. Alongside the founding dean, Dr. Kevin Sneed, she has provided and coordinated workshops with other presentations related to the management, vaccination, and related research focusing on COVID infections amongst a myriad of diseases. Welcome, Dr. Angela Hill.
Well, thank you so much, Dr. Standifer, for that introduction, and good afternoon, everyone. Dr. Standifer has kind of shared with you a little bit about my background and certainly the mission of We Care, and it's a pleasure to have Dr. Standifer and Ms. Eduard actually lead us in further discussion on why diversity really matters in research. One of the things that We Care is most proud about is attempting to bridge the gap between healthcare disparities by allowing researchers and the lay community to interact as much as possible. So we've developed programming that will provide education on processes and advancements in research for the community to try to tear down some of the barriers that have contributed to their inability or unwillingness to participate in clinical research. At the same time, we're developing programs such as this to actually enlighten the research community on the need for culturally tailored approaches as they try to recruit participants. And our hope is that this would help with retention. And so again, today we are going to explore some additional concepts that explain and reinforce our messaging that diversity does matter in research. And so we also would like to welcome the research community to capitalize on our research advisory board, which is composed of community members and members of our We Care team. And what we primarily do is actually communicate with researchers and appreciate the goals, the aims, the mission, and then that allows us to serve somewhat as conduits and assist in your recruitment efforts. And so we'll share that link with you so that if you have a proposal, allow us to work with you and be a resource to actually get you to some of the populations you may or may not have connections to. So again, we're excited about having you here. Dr. Sneed unfortunately could not be here today due to administrative priorities, but he does send his well wishes. And again, I just like to also share with people that We Care has been successful because of his visionary leadership and his passion for community outreach as well as outcomes. And he started We Care. It was named I Care, And prior to that, we had a Center for Health Equity, by which Dr. Standifer was a very important participate in the success of those efforts. And we've grown from just focusing on cancer disparities to looking at all aspects of health inequities and disparities, such as COVID, as well as Alzheimer's disease, mental health, and of course, continuing to push our mission as it relates to research and truly trying to advance the research mission of the university. So not only do we invite you to capitalize on our advisory board, but also we have a video library by which you'll find this and other recordings of some of our previous work, particularly since the pandemic started. So again, thank you for coming. We hope that you enjoy the content. We encourage you to utilize the chat if you have questions, and certainly if there's anything that we can do to certainly help make your research efforts more successful. Understand that We Care cares. So with that, I'll pass the baton back to Dr. Standifer and Ms. Eduard. Thank you so much for coming today.
Well, thank you, Dr. Hill. And if you could advance to the next slide. I will provide an overview and then I will introduce the co-moderator. And again, just to highlight that we, again, are excited to be a part of this initiative, educating, informing, and training. The webinar today will focus on diversity matters. We had a session last week. We wanted to highlight, or rather recap, diversity matters in research. Part 1, we'll talk about the importance of cultural humility, sensitivity, competence, and congruency in healthcare and research settings, and discuss implicit biases. What is it, and the importance of acknowledging our biases. Next slide. So, without further ado, I will introduce my co-moderator this afternoon, is Ms. Pascale Eduard. She is a passionate public health enthusiast with an interest in advancing public health practices, policies, and addressing health inequities. Ms. Eduard earned her Master's of Public Health degree from Florida A&M University's Institute of Public Health in 2012, where she found her passion for public health. She is a public health doctoral candidate at the University of South Florida's College of Public Health, making strides toward graduating this summer. We are going to claim that for her. Her research interests include the intersections between racism, residential segregations in health, health inequities, and immigrant health outcomes and quality of life statuses, using the critical race theory as the foundation of her research. Currently, her dissertation project is an exploratory study assessing the impacts of residential segregation on type 2 diabetes management among African Americans in Florida. Today, Ms. Eduard will address cultural humility and a few other cultural competency impacts. Let's welcome Pascale.
Thank you so much, Dr. Standifer. So just to kind of give you all a recap on what we all discussed last week, we started off with an introduction or highlighting some of the historical and contemporary examples of mistreatments among communities of color in both the research and the medical setting. So we talked about J. Marion Sims, who's recognized as the father of modern gynecology, and how he used the bodies of Black women, enslaved women, to do experiments and come up with the vaginal speculum that is widely used in OBGYN and gynecological services today. We also talked about and discussed Henrietta Lacks, whose cervical cells were unknowingly took from her body after she passed away, and is commonly used as, or commonly known as, the HeLa cells, which are used in a lot of genetics type research to come up with like vaccines, like for example, the COVID vaccines and polio vaccines that are also very popular today. We also talked about the famous Tuskegee syphilis study, and also the history of modern sterilization among women of color throughout the United States. And we also talked about the contemporary ways that people are mistreated within the medical setting. So we highlighted how the LGBTQ community is mistreated within the healthcare setting, as well as when it comes to maternal health outcomes or maternal mortality rates among Black women, and how they're also mistreated within the healthcare setting too, and how that contributes to the high maternal mortality rates. In addition to those things, last week we talked about implicit biases, which we'll explore a little bit more today. We also talked about the current perspectives on the mistreatment of bodies in communities of color. We specifically highlighted and focused on police brutality and how that has negative implications on the mental health of individuals who experience brutality at the hands of police. And then we also discussed the importance of the disaggregation of health data among racial and ethnic populations, because some of you all may know that, although we may belong, for example, within the Asian American community, the Asian American community is very nuanced, and there are subgroups of Asian Americans or people within that particular racial ethnic group who experience health outcomes differently from the overall group of Asian Americans. And we closed with just talking about some policy implications and what are some needed next steps to mitigate the mistreatment of communities of color within both the medicine and research. So kind of building off of what we talked about last week, today what we want to discuss is highlight is are ways that we can kind of be progressive in the way that we do medicine, the way that we engage in research with communities of color. So I am going to discuss cultural humility and sensitivity, both within the healthcare setting and the healthcare, medical, and the research settings, and their importance when it comes to addressing health disparities. So before we can begin to understand cultural humility or sensitivity, we have to understand what is culture. So culture is defined as the belief that we as individuals and communities So culture is defined as the beliefs that we as individuals and communities hold about reality. So these include the norms that guide our behaviors and values that orient our moral commitments. In addition to that, culture also encompasses the symbols through which our beliefs, norms, and values are communicated. Daily, we operate and interact with various different cultures from our personal family cultures to societal cultures and cultures that we may not belong to or may not be familiar with. So in order to understand and better navigate the various cultures that we may come in the contact with that we do not belong to, it's important that we have cultural humility. So what exactly is cultural humility? Cultural humility is a process through which we engage in self-reflection and discovery to better understand both our personal cultural beliefs, norms, and values in relation to other cultures. So the way that I like to describe cultural humility is that it's almost like an invisible backpack that we carry, right? And so in this invisible backpack that we carry, we hold our beliefs when it comes to racial ethnic groups. The people, we also hold beliefs as far as the people who belong to different classes, religions, and have different immigration status, or different beliefs when it comes to people who have a different gender from us, their gender, sexual orientation or preference, and as well as we hold beliefs when it comes to the linguistic capabilities of people. So for example, people who speak another language that we may speak or who might have like a heavy accent when they do speak English, right? So when it comes to our cultural beliefs and views, what actually shapes our views of others? So there are a multitude of things that shapes our cultural views and beliefs of others. And these include our family background. So like our family experiences and values that we're exposed to as an individual. In addition to our peer influences, how our friends and our peers contribute how we view other people in the culture that we either may belong to or a culture that may be different from ours. In addition to that, the communities and neighborhoods that we grow up with also shape our cultural beliefs and views, in addition to the political affiliations that we might be a member of. So when we think about cultural humility and the ways to address it within the healthcare and research setting, there are three things that are required. The first thing that's required is that we have personal reflection. So personal reflection as far as how is it, how do I have personal reflection in relation to your own personal self-discoveries, or exploring how is it you view different cultures in relation to yours, right? So that's one aspect of cultural humility. However, another aspect of cultural humility is professional reflection. So the organizations that we work for and that we belong to and the institutions that we're a part of also shape our cultural views and our cultural humility. So exploring how our professional settings shape how we view society or view various cultures that might be different from us, and how we work with those different cultures are also important, especially when it comes to like the research in the medical settings. That particular professional culture that we're a part of impacts how we view or how we practice research in medicine. And then lastly, for those of us researchers in the room, when we think about how we show up in the research that we're conducting, because again, going back to that invisible backpack, we don't leave that invisible backpack at home when we go into our professional setting or within the research setting. We take that invisible backpack with us into the research setting, right? And so that invisible, those various perspectives that we have as far as race and ethnicity, gender roles, gender identities, or what have you, those show up in the work that we engage in. So as researchers, it's important that we acknowledge our cultural perspectives and how they influence how we show up in research and how we conduct research. And then also how it is that we interpret the findings of our research too, that go on to impact various different cultures or races or ethnicities, if you will. So moving along to cultural sensitivity. So while cultural humility focuses on self-reflection and discovery, cultural sensitivity does not happen so much in a vacuum, right? So cultural sensitivity is defined as applying knowledge, consideration, understanding, respect, and tailoring after the self-reflection and discovery process and interacting with people with different cultures. So when we look at cultural sensitivity, a couple of things happen with cultural sensitivity. Before we can even get to cultural sensitivity, I think what we have to do is immerse ourselves in diverse environments, increase or heighten our awareness as far as how we navigate those different environments that we're a part of or that we may not be a part of, and how our perspectives or our views are either impacted or how we relate our personal perspectives or views in those various different cultural settings that we may be a part of or may navigate. In addition to that, also having encounters with people from different backgrounds with you too also influence our cultural sensitivity. So diversity, awareness, and different encounters are very important when it comes to getting the cultural sensitivity, excuse me, that is important when it comes to healthcare research, medical practice, and as well as just general public health research, if you will, too, right? So with those antecedents that we have, these ultimately lead to shaping our knowledge, right? Our knowledge and the considerations that we have for the various cultures that we may come in contact with. And it also helps frame our understanding of various cultures that we might come in contact with. And with that understanding, we begin to develop a sense of respect for cultures that are different from us. And then when it comes to research or shaping interventions or programs, for example, with those different cultures, we begin to tailor those programs to meet the needs of individuals or groups who may belong to a different culture. So like an example that I like to reference, because it was like my previous dissertation focus before the pandemic, is addressing type 2 diabetes in a culturally responsive or culturally sensitive way. So for example, with the CDC's type 2 diabetes program, it's a one size fits all model, but we know that when we're engaging with different cultures and different groups of people, a one size fits all model will not address those needs when it comes to managing type 2 diabetes, right? So tailoring such a program to actually meet the needs of different cultures will be an important way of actually helping move the needle when it comes to addressing type 2 diabetes inequities among different racial ethnic groups. So once we get to cultural sensitivity, there are some positive benefits that come with cultural sensitivity, and these include effective communication with different people that we're interacting with, effective interventions in the research world or in the medical world too, and as well as leading to satisfaction among those who are actually engaging in those interventions or engaging in communication, for example, within the healthcare setting. So kind of rounding out, the importance of cultural humility and sensitivity in research. Why is this important? So again, it's important because it can lead to increased participation of marginalized groups in research to include clinical research trials, which we know and data shows that people of color are less likely to engage in clinical research or just research period because of the historical trauma that Black and Brown and Indigenous people have experienced throughout history when it comes to research and experimentation. In addition to that, the importance of cultural humility and sensitivity in research can lead to the development of effective interventions and drug treatments. Because as I mentioned, a one-size-fits-all approach is not the most effective approach. And then ultimately, with increased cultural humility and sensitivity in research, it can lead to the elimination of health disparities and inequities among people of various different races, ethnicities, and marginalized groups. So with that said, I am going to move on to the implicit biases and just kind of highlight or explain what implicit biases are and the importance of acknowledging our biases. So what are implicit biases? So implicit biases describe the attitudes or stereotypes that contribute to our understanding, actions, and decisions. Again, implicit biases also, cultural humility and sensitivity, as well as implicit biases are all different components, but they all kind of intertwine with each other when it comes to addressing medical and research distrust among communities of color. So some key characteristics of implicit biases include that they're pervasive. Everyone has implicit biases. And with implicit biases being so pervasive, they're both unconscious and subconscious. It's not something that we think of. These are just embedded in our way of thinking, right? And influence or contribute to our feelings about people based on race, ethnicity, age, and appearance. And so when we think about implicit biases, these might contribute to having either favorable or unfavorable assessments of people from different backgrounds other than our particular backgrounds. And when it comes to implicit biases, we also tend to favor groups that we belong to. So for example, with my implicit biases, I'll tend to favor individuals who belong to the African-American community or the Black community, if you will. And what exactly shapes our implicit biases are either both direct and indirect messages. And this also goes back to the to cultural sensitivity and humility as far as what shapes our views of culture, our views of cultures that are different from us. So these could be from like direct messaging from our family and the societal messaging that we're getting, and also indirect messaging. So what we're gonna do really quick is I really want to take some time for you all to kind of explore your implicit biases. So I am going to put up a link in the chat for you all to pull up, if I can do this really quick. Here. Okay, so I'm putting this link in the chat to the IAT test, implicit association test through Harvard. And you can just briefly skim, or if you want to read the full thing as far as the preliminary information, go ahead and do that. And then once you do that, at the bottom, click I wish to proceed. And what I want you to do with the test that you're going to select the age IAT test and take about, give or take 7 to 10 minutes. I'll check in at 7 minutes to complete the age IAT test, and then we'll debrief and discuss some questions relative to the test that you just took. So it's about 12:30 now. So I'll check in at about 12:37. Or for us in the Midwest, 11:30. I'll check in at 11:37.
Ms. Eduard, we had a few people join us late. You may want to either put in the chat the instructions or repeat them so they can catch up.
Okay, sure. So for those of us who are joining late, I put a link in the chat for the Harvard implicit bias test. So once you click the link, just quickly read the preliminary information, and towards the bottom, click I wish to proceed. And then from there, select the age IAT test and take about 7 minutes to complete the test. And I will check in with you. For those in the Midwest, I will check in at 11:37. And for those who are on Eastern Standard Time, I will check in with you at 12:37. Here, I'll put it in the chat again. I just put the link in the chat again for those of you all who are just joining and didn't see it before. We have about 2 more minutes. Okay, so it's 11:37, and I do want to check in. If you all are still working on it, press the, well, if you're done, put a 1 in the chat. If you're still working on it, put a 2 in the chat, just so I can know. Okay, still working. Okay. Okay, I can give you all about another 5 minutes and see how that works for everyone.
Do you want us to put ones in the chat when we're done?
Yeah, once you're done, go ahead and put a 1 in the chat. So you have a couple of ones coming in. Some of you all are completing it or have completed it. Okay. So in about a minute, we'll go ahead and kind of debrief. I see some thoughts coming in through the chat. So I'm interested to hear what you all have to say. As far as like your results from the implicit, the age IAT test. So what it's 11:42 now, and if you're still working, that's fine. You can just jump into the conversation once you're done. So based off of your results, what was it like to take the IAT test? If you would like to perhaps raise your hand, and I will have you unmute your mic. Do we have the reactions for this here? Okay, so how do you raise your hand? There you go, perfect. If you look towards the bottom of your screen, you'll see the reactions with the happy face. So the first person's hand that I see up is, and sorry if I butcher your name, is it Daisha Reed Holden?
Disha.
Disha. Okay, what was it like, Disha?
I feel like if I had to have a preference, my idea of my preference prior to this test would be older people, because I grew up around older people. My parents are a generation removed from me. They were older than some of my friends' grandparents. So, I feel like I like to hang out with old people. I like to party with old people, and the results didn't reflect that. But I know that my experiences primarily with white older people have not been great. And I'm wondering if maybe that has something to do with my results, because there was not a lot of diversity in looking at these images. And if you're just going off of, your biases, well, I'm going off of my experiences, and I'm not here for the older white folks. Like, not that I'm generalizing everybody, but in comparison, no. So I wonder if maybe that lack of diversity in these photos, and I've taken a different test, but in the same program, and it was the same type of lack of diversity. So thank you.
Thank you, Disha. And that really speaks to, again, why we're doing this, the diversity in the IAT test, how there is a lack of diversity in the IAT test that you picked up on. And so that kind of speaks to how that might skew some of the results from the data that, the IAT test is gathering. The second person whose hand I saw up, I think it was Nikita. Was that by accident?
I can talk. Did we have different tests?
No, everybody had the same test, the age test.
Oh, okay. I had a sexuality test.
Oh, okay. I mean, if you did that, that's fine. If you want to go ahead and share what it was like.
I'm sorry. I guess I probably missed the beginning of it. So the thing that I found odd was when I went to go click good, it wouldn't allow me to click good or bad.
Mm-hmm.
It only allowed me to click what the couples represented in the picture.
Okay.
So mine was different. It was
Yeah.
a different experience. Yeah, it was very.
Okay. Well, thank you, Disha and Nikita, for sharing. If I don't see comments in the chat, I see your comment, Disha. I think Kim put in the chat, I found my results interesting because I tended to young people, but my master's was, so she more so favored young people, but her master's was in gerontological nursing. Interesting. That is interesting, Kim. Let me see if anyone else put any. I think those are just our 2 comments in the chat. Hopefully I'm not missing anyone. Okay, so moving on to the second question, if anyone would like to share. Were your results what you expected? Why or why not? If you want to raise your hand, and I'll have you unmute. Got a quiet group today. Okay, so Dr. Hill's hand is up.
I only put it up because no one else was putting theirs up. But like the last person, I found it interesting that most of my patient interaction is with older individuals. But I'm thinking, but I tested out to be biased to younger individuals. And I wonder if it's because I'm an educator and most of my teaching is with, younger individuals. And I'm also a mother of 7. So I'm wondering if maybe some of that influenced it. But I saw the same things and thought the same things as was previously said.
Yeah, same. And I can share, like, when I don't see anyone else's hands. When I took the test too, I more so favored younger people too. And I mean, I still think that I'm young. I act young and I'm an educator too. So all of those things I think maybe play a role in it. I think it's also interesting too, like, I mean, if we were, once I am a little bit more seasoned, if you will, do we still have those preferences? That'll be interesting to see. So anyone else? I don't see any other hands and I don't see any comments in the chat.
Christina.
Christina.
Yeah.
If you might want to unmute yourself, Christina, if you're speaking.
Sorry, I had to find the setting for it. It told me that I did not have a preference between older and younger individuals, which I found interesting because even as a child, I was always more comfortable with older folks than I was with people my own age.
That's interesting.
Yeah. And it hasn't changed. I'm an older adult. I mean, I feel very young, but I'm an older adult and I still feel like I'm more comfortable with people older than myself.
I think it's interesting that you said that the test, you're kind of like in the middle, right? Where you don't have a preference for either. So that's interesting too.
That's what it said, yeah.
Yeah, that's really interesting. And then last question as we debrief, and then we'll move on is, regardless of whether you expected them or not, how do you feel about your results? Miss Kim Smith, if you'd like to go.
It really, sorry, I was trying to, there it is. It really makes me kind of question the results, knowing what Disha said about the fact the test may be biased. There's no racial diversity showing in the photos. So it makes me wonder what other bias may be in there as well, and how valid are my results truly.
Yeah. I don't know, maybe one of us could, kind of, email Harvard and say, hey, if they haven't already thought about that, and then how can they incorporate the diversity within the test, just to kind of address that. Would anyone else like to speak on that question? Christina's saying, I agree with Kim. That's a very strong point. I think a couple of us have the same sentiment. Okay, since there are no other hands up, what I am going to do, I am going to give the mic, well, actually, before I give the mic back to Dr. Standifer, I want to close out with saying why is it important that implicit biases are addressed in research? Really because science and research doesn't happen in a vacuum. There are a lot of outside or external factors that influence science and research. And these include both the time and place in which they're carried out in, as well as the societal culture and institutions that influence research and science, right? So when we think about implicit biases play a role in the generation of evidence from conducted research. So this kind of goes back again to, how you as a researcher or a medical practitioner are showing up within the research setting. And as you conduct the research and as you analyze the research, you're also influencing how you're interpreting that data that you're getting from the research that's being conducted. In addition to that, implicit biases also play a role in the recruitment efforts in processes. And so while the IAT test doesn't necessarily have to do with the recruitment, but kind of going back off of what Disha mentioned, as far as the lack of diversity in the test. So, that can lead us to make assumptions or have conversations about, okay, who created the implicit association test and how did their biases show up in the development and the creation of the implicit association test is important to recognize as to how, and recognize and acknowledge how implicit biases play a role in the research that we are carrying out as researchers and medical practitioners. However, on the medical practitioner side of things, what I am going to do, I am going to turn the mic back to Dr. Standifer, who will speak on the topic of implicit biases in healthcare delivery and access.
Thank you, Pascale. Was there another slide prior to this one? Let's see.
Oh, yes.
Yes, okay. Just wanted to make sure if you can go back one more.
Oh, I don't know how.
Yeah,
I
there are
did
a few
that.
slides. Can you go?
I jumped 3.
But yeah.
Hold on.
Okay, no problem.
Yeah, let me do it this way.
No problem, but thank you. Just in terms of, and I'm going to bring up a few.
This is the first slide.
Components. Okay, can you go back one more? Let's see, one more.
So if I go back, it takes it back to what I just spoke
Okay,
about.
so that's
Do you want me to
fine.
go forward?
Yeah, no, you can go back. Yeah, stay
Okay.
on 23. Thank you so much. I just wanted to make sure that we're highlighting the current slides in terms of, just talking about what everyone shared in terms of the results. And thank you so much to highlight cultural competency, to highlight cultural congruency, and to really kind of just be aware of what is occurring within yourself, the biases that we all hold, the biases that the creators at Harvard hold for test development. Right? We know that this is true when we have our own kind of development and perspectives and through our lens, through our eyes and the way that we see it. And so we have to be very conscientious of that. And particularly for, we talk about researchers and community organizations and all the stakeholders that we have here in our audience today. But when you are interacting with providers, you are interacting with any healthcare delivery processes and access. And even as the provider, I think Dr. Hill talked about this as well, as you come in and thinking, oh, I think I'm serving an older population, but how am I really feeling and where am I situated? And so really understanding that what implicit bias is when you're looking and working within the healthcare delivery system. And so when looking at this, we need to understand that substantial attention has been paid to the possibility that unconscious bias, right? This is another term for implicit bias among healthcare professionals contributes to health disparities. In 2003, there was a seminal publication called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, published by the Institute of Medicine, right? This is the premier academy and institution that focuses on treatment aspects of delivery and access research, producing this to talk about what's happening with the American healthcare delivery system. And so the Institute of Medicine concluded that unrecognized bias against members of social groups such as racial ethnic minorities may affect communication. And actually it showed it does affect communication or the care of those who are offered, certain treatment options. So I just want to make sure that we are highlighting what has been shown, evidence-based literature and research. And then how does that happen? We talked about this in our part 1 discussion of our series, and you can go back and feel free to review that one. And thank you for those who are coming back. But we really want to situate this when we're looking at healthcare delivery and the providers. Next slide, please. And so when we're looking at implicit biases are of concern to healthcare professionals, they're to operate, often those that operate to the disadvantage of those who are already vulnerable. We call them vulnerable, marginalized minority populations. And so those who don't have a voice, minority ethnic populations, immigrants, poor, low health literacy individuals, sexual minorities, children, women, elderly, the mentally disabled, the overweight, and of course the physically disabled, but anyone that may be rendered vulnerable given this particular context. And the vulnerable in healthcare are typically members of groups that are already disenfranchised, disadvantaged, and don't have a voice or even a seat at the table in so many levels. And we're working within the political philosophy, such as some of the philosophers, Deschales and Wolff, their concept of corrosive disadvantage, right? And this is a disadvantage that is likely to lead to further disadvantages. Some people call it cumulative, disadvantages, but this is corrosive, meaning that it's building and building and building and just being corrosive and destructive toward a population or an individual. Next slide. So when we're looking at the presence of implicit biases among healthcare professionals, healthcare practitioners, and the effect or the impact on the quality of care, it's really a concern. And so many of you are working within these populations, you're working, conducting research for, but you will be the voice through your research, through your organization, as a stakeholder, through a community member. You are the voice. And there is critical need for the healthcare profession to address this role of implicit biases in disparities within that our healthcare system. In addition to addressing implicit biases, there are measures that need to be taken to raise awareness of the potential conflict between holding negative explicit attitudes towards some patient characteristics, such as obesity, and committing toward a norm to treat all patients equally. We find this a lot, of course, as I want to highlight with obese patients. And so, you have narrative and qualitative research showing that when obese patients are, the communication that happens, that patient-provider communication, it's often toward a negative perspective and the victimization of obese, as Pascale talked about, by diabetes. And we don't have alignment with some of the management and the treatment options because of lack of transportation, some of the social determinants of health. We highlighted last week, transportation, health literacy, already disadvantaged, perspectives in that context. So what do we need to do? How do we do this? And so the concept I'll just add about being culturally competent, being aware of what is going on, that framework of that patient, we're calling it patient-centered care now, but also being within that whole person and that patient being centered upon their particular perspectives, right? And being culturally sensitive and culturally aware of what's going on with a disabled a woman who is maybe going through menopause, not able to really kind of identify, and maybe from a refugee community, right? And so right there, we're calling it corrosive or cumulative disadvantages, especially within the healthcare system. And we're talking about individuals that may not have full or complete coverage for healthcare access and treatment. We really need to be very aware of this, particularly from the provider side. And so we're needing more uniform methods of research and care practice to enable better comparison and communication between researchers interested in different forms of biases. Looking at the important avenues for further research, including examination of the interactions between patient characteristics and between healthcare professionals and looking at possible ways in which to tackle the presence of implicit biases in healthcare. As we talk about cultural competency, we also need to look at cultural congruency. And that is, again, looking at as a provider, how do I make sure that I am in alignment with what a patient wants and what a patient needs, and not what an insurance company wants. Okay, so sometimes it may take more than 7 minutes, as we know that it often requires providers to take, but taking a little bit more, or being very empathetic, often it's called, or sympathetic, right? But then understanding that not all patients may want the type of care that you have been trained to provide. And so when you're dealing with, as we mentioned, immigrant populations or refugee populations, it may be among populations or populations that don't seek, traditional treatments, individuals from religious communities that don't want care, i.e. vaccines, and I see certain coverage, right? We need to understand that it may be conditions of illness or sickness, and the way that a mother wants to deliver her baby, whether it be in a birthing center, whether it be with a doula. We have to understand, if that is the request of the patient, we have to be culturally congruent to our delivery of that care for that mother. So understanding that, whether it be the death of a person, understanding there are death doulas. And so if someone would like to be assisted and provided for in their death process, this is what providers need to understand. And this, again, is being very inclusive of biases in our particular care and delivery system within the medical profession. So I thank you so much. Next slide. We are now turning it back over to Dr. Hill, who will engage us in a very interactive activity and then conclude the series. Dr. Hill.
If you can give me host privileges and you all stop sharing the screen, I'll be able to take over. But first, I'd like for everyone to join me in using the reaction button and giving Dr. Standifer and Mrs. Pascale a round of applause for that great overview of implicit bias, as well as things related to cultural congruency, I guess we'll use as an overall term. Really learned so much. The IAT activity was just really wonderful in terms of helping, I think, enlighten all of us individually about some of the things that we may be thinking about subconsciously, and how it influences our behaviors, both in the healthcare environment and certainly the ramifications as we talk about research, recruitment, and retention. So I just so wish there were others to hear and appreciate this information, but I'm glad that we've recorded it so that people can go back at a later point. So yes, we thought we would do something fun to kind of lighten it. We've been talking about some really intense, and we know borderline sensitive kind of topics that often are not addressed as researchers like myself go and we take the CITI. These are not the things that we're walking away with from that experience. And so we do hope that you both find value and an appreciation in our approach to making sure that you're getting this kind of insight, because again, we just want the best in terms of your research efforts. So all of us should be familiar with the game Hangman. And give me a head nod, Dr. Standifer, if you can see my screen for Hangman. And so what I've done is actually identified just a few of the words and the terminology that was discussed over the past 2 sessions. And this will allow everyone to play and guess. And so what you'll notice is the little man hanging from the bundle of balloons. And so if you guess the letter correctly, he'll continue to smile. But as each balloon pops, you'll notice that he gets sadder and sadder, and we don't want him to get to fall. And that's the equivalent of hangman. So I will be rewarding the person that gets the most number of words correct. And so we'll see who's been paying attention these last two sessions. Okay, so this first word, I'm going to allow Dr. Standifer and Ms. Eduard to kind of give some clues to kind of get you started. So they are aware of the words, and we'll see if you all can guess it. So if you, just to allow everyone fairness and the fact that I've got to try to man both the game and the chats, I'm going to ask if you all would, if you don't mind, please feel free to turn your cameras on so we can all see and appreciate each other, but also use your raise hand function so that we can acknowledge you, and we'll see kind of how things go. Okay, so Ms. Eduard and Dr. Standifer, would you like to give a hint, just one hint for this first word?
Well, this first word I can highlight, I guess in more recent times, I know in the last year, there are some efforts from corporate America, from educational entities, as well as we know that even in the federal spaces. And so many of this is called, I can say we call some of these, I guess the first word of many of these offices, or an officer, often where you work. So it's three words. That first word would be and Office of Equity and Inclusion. So I don't know if I could.
Don't say anything.
I don't know if I say anything else. Yeah, but
Karen raised her hand. You want to give us a letter, or would you like to guess the whole word?
I'm going to go for the whole word.
Okay, okay.
I think it's diversity.
It is.
Great. Was that a good clue, or was that giving too much? I don't know.
It's a good clue.
Right.
And I watch a lot of Wheel of Fortune.
Okay, yeah. That's great.
Wonderful. So this one is diversity. So very, very good. So Ms. Karen, I want you to utilize the chat and please put your mailing address in there so I can get you your goodie for guessing the right word, and go ahead and let your hand down, and we will go on to the next word. Now, I'm not going to let them give as intent clues as Dr. Standifer did. She did really good. Okay, next word. Do you want to take this one, Ms. Eduard?
I can take this one.
Okay.
So the next word has to do with the overall content of what we just presented during last week's webinar and this week's webinar, and addressing cultural competency, implicit biases within the medical setting and the blank setting.
Okay. No more. I can see Ms. Smith thinking hard. Okay, Ms. Maribel raised her hand. What do you want to guess the word, or you want to guess the letter?
I'm gonna guess the word humility. Oh. Humility.
Oh no.
No.
What I have to do though is, because I know what the word is, I'm going to give you a pass, but this time what is going to happen is you won't be able to play the rest of this round, just since I'm not popping any balloons, because if I pop balloons, he'll hang. Okay, so if you could just kind of keep quiet just for this round and then join us in the next word. All right.
Okay, good.
Thank you. Let's see, Mrs. Callan, do you want to guess a letter, or would you like to guess a word?
I would like to guess the word, please.
Oh, okay.
Is the word research?
It is. It is. You guys are just too smart, but I tell you, our clues are just on point today, aren't they? Very good. So research, and that again is one of We Care's primary intentions with our mission to really improve research processes. Okay, so we are about to enter the world of two words. Let's see who can get this. So this should be kind of fresh on your brain. I might have to start giving the hints. because it was talked about today and alluded to last week. But what I will say, as a commercial, we're going to be doing a training in this area so you can have more experiences like what you did today with the IAT. So that's all I'm telling you. That's it. So I want you all to see if you can start guessing some letters so I can see some of these balloon pops. All right, Miss Kim, what do you think it is?
I was going to try and guess the whole thing, but if you want me to, I'll just give you some letters.
Let's see. Let's see.
Is it implicit bias?
It is. Very good. So you were paying attention. And so what did you walk away learning about implicit bias today, if you don't mind indulging us?
It's there. whether you realize it or not, I think every one of us has a little bit of some sort of implicit bias.
Exactly. And what I appreciated is, if you all want to go back to that link, did you notice all the different types of IAT tests there were? And we all have bias in all those areas, and whether we're aware of it or not, and I think another term for implicit bias that Dr. Standifer was mentioning before we talked was unconscious, bias. And sometimes we just function with no clue about us being an autopilot when it comes to some of this stuff. So very good. Thank you. So Ms. Smith, please put your mailing address in there as well. We have an email, but we want to make sure we follow up. We are so grateful for you all coming today. So we want to reward you all with something, and we appreciate your participation. Okay, let's move on. This next word is another two-parter. And I will I can't forget who, I think Pascale covered this content.
Yes, she did.
So don't give us too heavy a clue now. Make them work.
So with this particular word, it has to do with self-reflection and how we deal or interact with people from different backgrounds.
All right. Ms. Smith,
it's a two-letter word.
Did you want to answer again, or are you still stretching your hand, your arms? Okay. All right, Mr. Bailey.
That's my student.
I was gonna say cultural humility.
Very good. I tell you, these hints are great, or they've been paying a lot of attention. Great job. So again, please make sure that I have a mailing address so that I can get these gifts to you. And if you don't mind, after you answer the question, just let your hand down so I don't keep thinking that you want to say something unless you have a comment, or something like that. Okay. All right. So this one was, I don't know why it does that on the first. And you all are going to have to, at some point, let us get some wrong so we could see. See what happens. All right. Okay. Next word is, okay. So this was something that was covered in the first workshop and mentioned in the second workshop. And this is actually a person. And that will be all that I'll provide as a hint. So anyone want to take a guess at this one? I'm not going to give any more hints. Ms. Smith, you have your hand up? No? Uh-oh. Well, guess the letter. Guess the letter. Uh-oh.
A.
A. Okay, let's see. All right, 2 A's. All right, Ms. Kaylin.
Can I guess the whole word, or would you like me to take a letter or the whole name?
If you think you know it, let's see if you know.
Is this Henrietta Lacks?
This is Henrietta Lacks. Very good. My words are too easy. I'm gonna be mean today so you all can see what happens. But it is Henrietta Lacks. So Ms. Kaylin, can you tell us what you know about her story?
Henrietta Lacks is the person who unknowingly had her cells collected and used for research and development of the HeLa cells.
Yes, very good, very good. Have any of you all read the book? Who's read the book? Raise your hand.
It's an amazing book.
It is amazing, amazing book. And Nikisha read it. Awesome. And actually, there was a movie too that Oprah actually produced years ago. And the book I thought was better than the movie, but both were very, very good and very, very telling. And I really feel that all researchers should have this as a rite of passage, that they are familiar with this story, because it is just so monumental in terms of where we are in terms of research and research processes.
And
So
also, Dr. Hill, just want to add that Morehouse School of Medicine, we also host a conference.
Oh, really?
Actually, yes, every
That's
year.
true.
We actually haven't held it since beginning of COVID, but we hold a conference in honor of Henrietta Lacks to talk about bioethical considerations in research. So,
and I think something was something awarded to the family. There's a few of the descendants still living, but I think they may have been rewarded some money
from Johns Hopkins, along with the book. They created a organization. So
awesome, awesome. Well, we don't want those many, don't want those kind of stories to consider. Okay, so I do know that this is the last word, but Dr. Standifer talked a whole lot about it. Even I said this word quite a bit. Dr. Sneed, Ms. Eduard, this is really what pumps We Care's blood and establishes our mission. So let's see if we can guess this one.
That's all we're going to give him, Dr. Hill. Okay.
That's all we giving them. That's all we giving them. This is a smart group, so. Oh, they're quiet. Nobody want to guess a letter? So I want to hear from someone whom we haven't heard from, and I can't see the entire dais. And so the educator in me, I'm going to ask Mrs. Maribel if you would get the party started, because we kind of silenced you early on. Did you want to just guess a letter for us? Uh-oh. I mean, nobody even wants to guess a letter. Oh, Nikisha. Okay, what letter would you like to go with?
I'll guess A.
A. Okay, let's see. Very good. Very good. Well, did you want to go with another one since everybody is racing to?
Sure. I'll do S.
S. Okay. All right. Well, why don't you pass the baton to someone else? You know anyone else on the call today? Okay, we got some hands up. Kim is back at it.
How about an N?
An N. Let's see. Oh, okay. Very good guess. You want to pass the baton to someone else? Send a lifeline out.
I can't see anybody, but I know Christina was on here earlier.
Okay, Christina. Is it Christina Eshazabel?
Yes.
Okay, Christina, you want to guess a letter?
Let me go with H.
H. Good one, good one.
Okay.
Want to get another letter?
How about L?
Okay, L, and then we'll let, look like Nisserine may have had their hand up.
E.
E. Okay. You want to guess another one, Nisserine?
Can I guess the word?
Well, Nikisha had her hand up, but go ahead and see. Let's see. This one should be easy now.
Is it health? This is vintage.
Oh, dun, dun, dun. Let's see if Nikisha can get it.
I was gonna guess health insurances, but
Well, you all have the health part, right?
I got it.
Okay, Karen or Nikisha, but I don't know who spoke.
Oh, it was me. Is it
okay.
health disparities?
It is
That's
health
it.
disparities. Yeah. Great. Well, teamwork makes the dream work, right? So yes, this one was health disparities. And so again, that is the lifeblood for We Care and what we actually pride ourselves in trying to close that gap. And also, I want to really thank all of you for participating in the first version of We Care Games. And also Nikisha, Karen, Kim, Bailey, Kaylin, make sure that I have your mailing address so we can get your gift to you for participating today and just being brave and speaking out, because most times, particularly as well-educated individuals, oftentimes we don't like having to show our vulnerabilities and speak out like that. So I'm going to stop sharing. Let me see. I don't know what's going on here. Let me see. Stop sharing. Okay, stop sharing and see if anyone else has any questions. Now, Nikisha, your hand's still up. Did you have a question, comment, concern?
No, that was on accident. Sorry.
Okay. You might have still been stretching. I wasn't sure. But no, if we could get a physical mailing address from you, Nikisha, that we have something physical to mail to you. So it's beyond just an email address. But we want to just thank everybody for coming. And certainly, again, thank Ms. Eduard and Dr. Standifer for just really sharing such valuable information. And I think that you gave us a lot to really kind of chew on in terms of certainly trying to put it in context. The importance of just being aware of thyself is really the take-home message, I think, with all of this. So definitely we want to thank you all, but certainly for those of you in attendance, it just speaks to a need for us to kind of consider doing this. Miss Naomi, did you have a question or comment? I see you raised your hand.
Yeah, I just had one question that I've just been wondering from the beginning, like when it comes to implicit biases, like is there any research on like the direct effect of like implicit biases on like the effectivity of like people doing research, or like, is there any like direct relation to how it affects?
Well, I'll get started and then I'll pass the baton to the others. I too have dabbled into clinical research for a number of years as a pharmacist and also as a health professional, been involved with really high-tech clinical initiatives. And one of the things that I've noticed is that oftentimes I still remain the only Black or brown health professional, the only Black, brown female, oftentimes in many circles of care. And when it comes to research, I think sometimes in the desperation for researchers to just get participants, they may not intentionally, but subconsciously go the easiest route or the path of least resistance. So the effort may be minimal and unless forced sometimes to think about certain things. And that's where that unconscious bias or implicit bias kicks in. They may not even think about the fact that just like when we took the IAT, all of those faces were the same complexion and implied the same ethnicity. The only difference was that we could kind of guess at age. But a lot of times individuals don't see what they don't see. So they don't know and don't realize. But if I obviously look different than those, I'm going to be a little bit more attuned to the fact that there's no one else that looks like me versus the people that look like everybody else. And so I do think that there are domino effects in all of what we do, and it just plays out in the workplace. And I think she left, but Dee commented earlier, she grew up not being around a very diverse group of people. So she wasn't aware of it, didn't think it was wrong, and went on about life. And it wasn't until she got in situations where she thought differently. So most times, if we know differently, we do differently. But when we don't know, we don't know. So yes, I do think implicit bias is real, and it does impact things like research recruitment extensively. You all want to comment? Mm-hmm.
Yeah, I will add, I did place some resources, particularly focusing on the Institute of Medicine, some of the research that has come out of that report as a result of the Institute of Medicine. Naomi, I think you were here just highlighting that a few studies were conducted where we talk about pain, and when various race and ethnicities, the Institute of Medicine, conducted a study when African Americans were brought in and complaining about pain in their right shoulder or the right arm, and what can I do about this, bad pain? And comparably, a white individual came in. The African American was just giving a Tylenol and told to go home and sleep it off, as opposed to white individuals who were possibly giving, prescriptions, opioids, which lead to another issue. But we're giving a very different type of treatment and regimen and a different medication, and they're showing how it does impact over time, that if a pain, you're just giving someone medicine, ultimately that can be even, with some treatments, let's get an x-ray, let's get an MRI. But instead of that, you're just given a Tylenol, as opposed to, someone of another race, ethnicity group says, hey, well, let's go and get an x-ray. Let's go in there. And that has been shown and evidence provided in the Institute of Medicine report, along with others that have come afterwards. So I provided just a few snippets of that. And then I think we highlighted that Pascale did as well, some of the studies that were presented last week. But there's a lot of research that is there and now being corrective. We're now being restorative in what we're doing. And so many medical schools are saying we need to incorporate this in our curricula. And that's what we're doing at Morehouse School of Medicine. I know throughout the nation, people are saying, hey, well, how do we incorporate implicit bias into medical school curriculum, nursing school curriculum, PharmD curriculum, and to increase the attainment and the recruitment of African American, Latinx, other populations that have also, as Dr. Hill talked about, not been so prevalent in the room at the table, but now offering more, offering more opportunities to Black doctors, Latinx doctors, other populations that not have normally been, in the room or even on the surgery table or performing those surgeries. So just highlighting that there is evidence supporting what you just asked, Naomi.
Okay, thank you so much.
You're welcome.
I forgot to introduce myself. My name is Naomi, and I go to Augustana College, and I take Introduction to Public Health with Professor Pascale.
Awesome.
Awesome. Well, what we would like to do with our last few minutes, again, invite anyone, if they'd like to turn on their cameras and or introduce yourself through the chat. Let us know where you're from. We will be having more programming like this. Our next one we're planning is dealing with implicit bias, a little deeper dive, and our own Dr. Austin will be leading up a workshop that will even be more intriguing. Just today, because of time, we thought we'd whet your palate and let you kind of know really how serious this stuff is. But we really want to keep you in our family and help you as you go on your journey to become successful researchers. And I do think that taking time like this to advance yourself and sharpen your saw in this area is just really going to pay off in great multitudes as you kind of go forward. But we also hope that you would consider yourself as almost a cohort of sort of researchers that are taking into consideration the importance of topics like this so that we can pass it on to the next generation of researchers, because you may very well go from being a student to the teacher, or instead of being a postdoc to being the researcher, the PI. And we hope that you would apply all of these different terms. So again, we do have everyone's emails, so don't be surprised if you get a flyer or an invite to future workshops. We hope that you will come back. We hope that you will share the the word about these kind of programs. We hope that when you see We Care, that you don't shirk away, but instead you smile and you click on that link and see what we're up to. We are continuing to do a lot of virtual programming, but we're also transitioning now to face-to-face events. And again, you're more than welcome, always invited to participate and come. We also are open to insights and ideas from you in terms of what you need and what you want and how we can help. So again, in light of our mission to kind of close the gap in health disparities, we thank you for being who you are. We applaud you for the successes you've had thus far in your careers, and we wish you much luck in your future endeavors. Again, thank you, Ms. Eduard, Dr. Stander, for coordinating 2 phenomenal workshops. Thank you so very much. We'd also like to thank and acknowledge Reach Up for making this possible. It is because of them that we're able to utilize this platform to reach individuals that typically we're not able to reach. So thanks everyone, and we hope that you all will also complete an evaluation that will be coming separate and after this, this meeting is over. So thank you again and enjoy the rest of your day.